Well, the outcome for children with Wilms tumor has improved dramatically over the course of the last few decades, but there's still those patients that do poorly, and we realize that if we want to raise the bar at all in terms of outcome for this group of patients, we're going to have to do a better job of identifying upfront bad prognostic markers so that we can identify those patients who aren't going to do well and intensify therapy for them. And so that's really what the study is all about, taking an identified bad biological marker and seeing if we can successfully augment therapy and improve the outcome for a group of bad acting patients. Many pediatric study groups are trying to do just what we've been trying to do, which is use some biologic marker which can predict for behavior of a tumor. And in the early 1990s, it was determined that this loss of heterozygosity, which is a deficit, a deficiency of chromosome material, was present on a recurring basis in patients with Wilms tumor, and sometimes in association with loss of heterozygosity of chromosome 1p. And then a retrospective review was done of the national Wilms tumor 3 and 4 studies, in which they determined that it appeared to be associated with a bad prognosis or worse prognosis, and that was sort of clarified with studies done in Europe as well. And so on the national Wilms tumor 5 study, which was the last big North American multi-center trial, we prospectively evaluated whether this was indeed the case and whether in fact the loss of heterozygosity of chromosome 1p and 16q were associated with worse prognosis, and it was found to be so, and it was a significantly worse result, worse outcome for patients who carried these chromosome findings. And so our attempt with the studies we've just conducted was to see whether by augmenting therapy we could overcome these adverse biologic markers and of course not subject the patients to excess toxicity at the same time, which is always a concern when you're going to augment therapy. And I think we've been successful in showing that, which is a very exciting finding. So previously on the National Wilms Tumor 5 study, patients with stage 4 were treated with a regimen called DD4A, which comprises vincristine, doxorubicin and actinomycin, and we have a lot of experience with that regimen. But we also know that cyclophosphamide and etoposide are active agents in the treatment of high-risk Wilms tumor and unfavorable histology Wilms tumor. And so we created a new regimen, which was DD4A plus the addition of 4 cycles of cyclophosphamide and etoposide, and we call that regimen M. And we've used these combination of drugs before, but not in this specific combination with these specific doses of drugs. And we were encouraged that we had a marked improvement in outcome and that the toxicity on regimen M was manageable and not out of expectations in terms of the kind of treatment that we were giving. So our primary findings were that for stage 1 and 2 disease who were treated with the addition of doxorubicin, so EE4A plus the addition of doxorubicin, there was a trend towards improved survival for patients with LOH1P and 16q who got the augmented therapy, but it was a very small number of patients and we didn't show statistical significance for the stage 1 and 2 patients. However, for the stage 3 and 4 patients, the advanced stage disease that we treated on this new regimen M, there was a statistically significant improvement in outcome for this group of patients. And we are very excited by these results. This shows that these biologic markers that everybody's been looking for to help risk stratify their patients more specifically and more precisely can be overcome with augmentation of therapy that is well tolerated. And I think that is exciting in that it spurs us on to look for other biological markers, perhaps in a higher percentage of patients, And I think it's exciting that we can move forward with this approach because we've shown that it can work. I think that loss of heterozygosity of chromosome 1p and 16q can be considered a standard of care for assessment of, certainly for the advanced stage patients with favorable histology Wilms tumor. And I think the take-home message too is that moving forward, it's exciting to be able to look for other biological markers that can help us, as I've said, risk stratify and then intensify therapy, because you want to intensify therapy for patients who are bad actors, but you don't want to do that for the good actors. You may even want to de-escalate therapy for the good actors so that they don't have any of the long-term effects that you may see down the road. So I think it's an exciting concept that we're happy to present here at the ASCO conference.